Excellent. Good afternoon, everybody. Thanks so much for joining on Zoom, and just go through the usual reminders real quick. As you all know, we're on Zoom webinar now, and if you are a member of the committee, please accept the invitation to join as a panelist. So those of you who, if you had hit decline for whatever reason, you really want to be on the panelist side, so please accept that. And the public comments may be a little bit slower just because we do have to convert folks when they raise their hand from attendee to panelist to properly participate. I think we are at capacity, so we're beginning the meeting. And as you could hear from the little recording, it is being recorded because this is a public meeting. The recording will be posted on our committee webpage shortly after the meeting concludes. And for everybody's reference, our agenda can be found under the first tab of the meeting materials that you all have. Dr. Zerzan-Thul, chair of the committee, will now call the meeting to order. Dr. Zerzan-Thul, on to you.
Great. Hello, everybody. It is now, I think, what time is it? 12:03. 2:03. And I call the July 25th meeting of the Advisory Committee on Primary Care to order. Thanks, everybody, for joining us today. So I'm going to start with an overview of the agenda, which is here on the screen. We'll start with roll call, and then we'll vote to approve the meeting summary of our June meeting. At 2:10, we'll open the floor for public comment. And then after that, Shane Mofford and Amy Clary, on behalf of the Center for Evidence-Based Policy, is going to lead us in a discussion of policies to support the achievement of the 12% expenditure topic. So I think we're going to have a lot to talk about, and I encourage committee members to ask questions and provide feedback to help facilitate our discussion. Yeah, as I said, I think there will be a lot to talk about. So thanks for all your time and efforts in being here today. So I'm going to call on members by first name in the order listed on the agenda, which is alphabetical by last name, so to keep you on your toes. And when I call on you, please unmute your microphone and let us know that you're here, and then go on mute again. So Crystal?
Here, thanks.
Great. Sharon Brown?
Here.
Excellent. Tony?
I'm here.
Great. Michelle?
Hi, I'm here.
Thank you. Nancy? Tracy? David? DC?
Hi, yes, I'm here. Thanks.
Perfect, thanks. Sharon?
I'm here. I actually have to sign off early today, and that makes me very annoyed because I really want to be in on that policy talk. That it is a board of directors meeting, so.
Oh, darn. Greg?
I'm here and unfortunately have a board meeting I'll need to leave for as well.
Okay, no worries. Chandra? Meg?
I'm here. Hello.
Hello. Cheryl? Lon?
Good afternoon, I'm here.
Great. Kevin? Eileen? Katina?
I'm here. Good afternoon.
Thanks. Mandy?
I'm here.
Jonathan?
I'm here. Hi, everybody.
Great. Sarah? Linda?
Hi, I'm here.
Thanks. Sean?
Here.
Perfect. Stacy?
Good afternoon. I'm here.
Hello. Ginny?
Hi, I'm here.
Excellent. And Maddie?
Hello, I'm here also. Good afternoon.
Great. Thanks to all of you. And now I'm going to turn it back over to Jean Marie, who will facilitate review of the May meeting summary.
All right, thanks, Judy. Appreciate it. And if you all would please join me in turning to the meeting summary and the materials. The recording of our previous meeting is posted on our committee webpage, and I will just start by asking if there's any discussion of the meeting summary in front of you all, or if you have any proposed changes. Not seeing any hands. No attendance corrections, no little typos, anything you see, doesn't sound like it. All right, would someone like to make a motion to accept the summary?
So moved. This is Katina.
Thank you, Katina. Any discussion of the motion? If not, all in favor say aye.
Aye.
Hi.
Any opposed? All right, the motion passes. And we will open the floor now for public comment, and I will turn it back to Dr. Zerzenthal.
Okay, we still have 2 minutes, so I don't know if I should dance a little bit or provide jokes. My 11-year-old daughter right now is really into jokes.
Oh, please do. Please do. Dance or tell a joke. I'll take either.
We were at Glacier National Park for a family reunion last week, and we were waiting for the shuttle bus, and the person that was organizing the shuttle bus was like, can anyone perform or do anything? And one of my cousin's kids used a stick as a baton, which was quite funny, and a little off balance because, you know, the stick isn't perfectly straight. And then my daughter told jokes, but I sadly can't remember any of them. So we'll have to wait till next time. I think we are now, I guess we're close enough.
You're close, but
Judy,
Judy, if you wanted to make the announcement that you had, that's also fine.
Oh, yes.
Yeah.
Yes. So Jonathan Staloff, who is on our committee, has agreed to be co-chair. There are times where I might not be able to be here, and so we wanted to find someone else to do that. He is a general internist working at the University of Washington, and I think he'll be great. So we will start to note that in the minutes, and he will hopefully gladly take the charge when I can't make it to these meetings. Jonathan, do you want to say anything? Wave at people.
Here's my wave. I hope it suits well for Zoomland. Thank you so much for the opportunity. Really, it's been a pleasure to be on this committee, and happy to be taking on an additional role. So thank you all so much, and a privilege to be working with all of you.
Thank you, Jonathan.
Great. Yes, thank you. It makes my job much easier. So that is great to know that someone can fill in if needed. So now's the time for public comment. And if you'd like to make a comment, we'll call upon you, have you raise your hand, and please state your name and affiliation, if any, before speaking. Please don't raise your hand more than once, so that helps ensure everybody gets a chance to speak. And you are also welcome to provide comments in writing via email at any time. Please remember that this is the time for public comments. Any Q&A later in the meeting is time for commission members to speak and ask questions. And with that, let's see if anyone would like to say anything.
And I do see we have a hand raised from one of our attendees. So I'm not sure who, I don't see a name, but I'm gonna briefly promote you. Or maybe you've already been granted the ability to talk. It looks like you have.
Hi, can you hear me?
Yes.
Yes.
All right. Hi, Shelby Weedman, Policy Analyst for the Washington State Medical Association. Thank you for the opportunity to speak. We are very interested in CMS's new Making Care Primary model and haven't heard much discussion on this lately. So I was wondering if this will by chance be covered in the HCA's upcoming webinar scheduled for August 31st, and separately if this group will be involved in this work. Thank you so much.
Great. Yes, we do have a webinar on the 31st to talk a little bit more about that, and CMS will be coming. There are also a number of CMS webinars that they're having to provide information about this. This is a Medicare venture that is Center for Medicare and Medicaid Innovation opportunity, I guess I'll say. It's not really a grant, and it is encouraged to be multi-payer. And so we have been in talks with CMS as well as other payers in the market about this. I think it is a very exciting opportunity. And I don't think we're talking about it today because, but maybe we can talk a little bit about it next time. I think there is a potential for that to increase expenditures in primary care. So that would be under the purview of this committee. And I don't know, did I answer all your questions? I think so.
And Judy, just to add on a little bit, we do have a bit of a reference to the Making Care Primary in some of the contextual parts of the materials today. So it's not covered extensively, but it's previewed slightly, and we wanted to make sure to make that connection with the work that we're currently doing. So, but there will be more to come, I'm sure, on that front later. So. Any other questions? I'm not seeing any hands.
Okay, great. Thanks for the public comment. And next, I'll turn it over to Shane and Amy to start our discussion of primary care data collection, barriers, and solutions, and talk about policies to support achievement of the 12% expenditure. Take it away.
Will do. Sharon, you're right to feel sad about this because it is going to be a very exciting conversation. So in a nutshell, we are going to be diving in on fleshing out some of the policy recommendations that we started discussing in prior meetings. And I think there's just going to be a lot of really robust conversation about these because it's interesting policy and it'll be impactful. So let me pull up a deck here. And I'm actually going to leave it in edit mode, and we're going to do some real-time editing here. So don't be disconcerted if it doesn't look quite like you're used to seeing. All right, can you all see that? Thanks, Jean Marie. Okay, great. So like I said, the goal for today is to review and refine draft policy recommendations supporting the achievement of primary care expenditure targets. Just as by way of grounding, we're talking about really focusing on the increased expenditure for primary care. This is a refresher on the general definition, just to get people focused on where we're going to be working. I'll leave this up for just a moment here. To give you a chance to refamiliarize yourself with the definition. All right, and let's keep going here. So as you remember, the committee is charged with multiple assignments, and we've categorized them into the primary care definition, data reporting, which includes barriers and how to solve for them, tracking expenditures and whatnot, And what we're really focused on today is the policy set. And that includes recommending methods to incentivize achievement of the 12% target and recommending specific practices and methods of reimbursement to achieve sustained primary care expenditure targets. I would note that as part of the approach, we've used a slightly different framework. We're thinking a little bit bigger picture, recognizing that it's not just about payment. You have to think a little bit broader to ensure that you have a system that's capable of receiving the funds while increasing access and providing appropriate utilization. So you'll see that the policies we talk about go a step further than what the charges are, but they are all directionally aligned and ultimately all needed for any payment policy to be effective. So for today, as a reminder, this committee, we did some polling and we looked at some policies from other states, and we generated an initial list of ideas to get the conversation started. Those ideas, they're pretty high level, and we really need to do two things. So we both need to refine the list of policies to recommend, and for those policies that are being recommended, we need to have policies that are sufficiently specific to be able to be sure that it's actionable. And we also need to make sure that the recommendations are realistic and feasible. And then we think there's also going to need to be a prioritization exercise associated with that as well. So before we dive in on talking about the specific policies, as part of making sure that we have actionable and feasible policies, we want to make sure that we're grounding this conversation in a set of principles. And these principles will serve as a test of, are these policies reflective of what we want to advance back to the board and ultimately we'd like to see implemented? And the staff, we've taken a stab at drafting some recommended principles. These include an unambiguous link between policy and achieving the 12% primary care expenditure target. The policy recommendations have clearly defined action and actors, so it's clear who has to do what. The policies are feasible financially, operationally, and across competing stakeholder interests. And policies would result in improved access and quality, not just expenditure. One thing that I want to note here, since we're talking about feasibility, everyone at the table has a unique perspective and really excellent expertise, which is why you're here for us to draw on that. But it's probably going to be pretty difficult to, from your position, to understand what may be an operationally challenging policy versus one that's more easily operationalized, or maybe even fully understand the fiscal impacts. And so what we're proposing for the policy is, or for the process around developing the policies, is that we will work on refining the initial recommendations. We'll take that set of recommendations back to HCA and other state agencies as appropriate to get some feedback from the state on operationally, what would it actually take to implement that policy? Financially, what order of magnitude are we talking about associated with any given policy? Are there any other, getting at that concept of competing stakeholder interests, are there potentially unintended consequences for other groups as a result of implementing a policy? Actually, one of the policies that we'll talk about last is a pretty good example of that. So after the state has a chance to provide some feedback on the feasibility of each of the recommendations, we'll bring them back to you to further assess and then refine if needed, and then ultimately vote on the set that you would want to advance back to the board. So today, when we're talking about the policies, great brainstorming, try and be specific, but don't feel like you're on the hook for making ultimately a decision on it. By all means, flag where if you have questions about what this would look like under certain scenarios, raise those questions, and that can be part of the feasibility assessment. But looking at the specific policies and the drafts, or excuse me, the specific principles and the draft set we have in front of you, I just want to open it up for the group. Are there any principles that you think these policy recommendations should adhere to that is not accurately reflected here, or or that you would like that's not represented here, or that you would like to make modifications to what is here to better reflect your position? Jonathan?
Yeah.
Oh, sorry.
Hi, thanks so much. I really love this. Thanks so much for putting this together. Re-looking at the primary care definition we came up with, I appreciated that we had the word equitable in the definition, and so I'd love for that to be included in the policy principles as well. I think an opportunity might be in the last bullet. We could say policies result in improved access, quality, and equity, comma, not just expenditure. Thanks very much.
Thanks, John. And I see a hand from Sharon too. Sorry, I know you're still typing there.
Yeah, of course, I've got to get a comment in before I have to go. Sorry about that, but I just wondered, it's not necessarily a principle, but do we need to think about sort of budget neutrality? In other words, we can't necessarily add expenditure to the system. Is that something that we need to talk about?
I think we're trying to capture that under the feasibility area of financial feasibility. And additionally, I don't think that that's necessarily a constraint. To the extent some of these things may cost more money, particularly in the short term, and have maybe a longer term return on investment. I think we need to understand what the fiscal implications are, but I don't think that your policy recommendations have to be limited to budget neutral solutions.
Thank you.
Meg, I think you were first.
I'll also just say to that we're talking about improving a percent. And so, you know, that involves keeping the total constant in some way. It won't just work to add money to primary care if that grows both the numerator and denominator. That doesn't increase the percent. So I'll just say that.
I think that's helpful. I was trying to go there, and that's what I meant. So thank you.
Meg?
Thanks. My comments kind of lined up with that. I'm wondering if there might be value to capture this discussion in just referencing alignment with the overall cap on healthcare expenditure, the goal that's been set by the Cost Transparency Board.
I guess I could sort of take that one too. I think the overall cap shouldn't affect the change in percent of primary care spend. So increasing the percent of primary care spend involves putting more money into primary care, and whether if you invest more in primary care, that is what decreases your overall spend in unnecessary other areas, or people get more prevention or better chronic disease management so they don't have complications. You know, I think it all fits into part of getting to a lower overall spend. By increasing primary care is part of what will get us there.
And Linda, it looked like you had your hand up.
Thanks. So one of the things I guess I wanted to point out, and I'm not sure exactly how to figure it into as far as where the slide deck is, but it's this overriding piece that primary care got cut in 2013 to certain populations of providers, myself included, right? Nurse practitioners. So primary care was already cut 15%. There's only 85% reimbursement. And so I have a couple of concerns about that. I've had an overwhelming concern about that over time. But but the other piece I worry about is when we're looking at increasing primary care spend, you already have a percentage of clinicians who are only being reimbursed, not at 100% fee schedule, right? So, and I know we're trying to move away from fee for service, but we all know fee for service is a big driver still. So my worry is that to me, the playing field is at that current 100% reimbursement rate, not at 85%. So if I go up from the 85 to reimburse primary care, I can say I've increased primary care expenditure because I've made an adjustment there by whatever percentage to this group of clinicians, but it doesn't necessarily, I think, achieve what we're trying to get going here. So as a base piece, I know that requires our legislative action going forward, but so to me, I worry about sort of, let's call it a loophole, and also, and quite frankly, where it sits right now and what it sets us up for.
I've taken a little bit of liberty here because I think at the end of the day, it's going to be hard, like benchmarking to a historic level is going to have challenges, just like how you interpret that in today's context, particularly since, there's been a pandemic since then, and it's, all sorts of innovation, greater telehealth. So would it be fair to say that as a policy for our recommendations, that policies have to lead to sustainable levels of reimbursement for let me maybe put all primary care providers included in the primary care definition? Would that adequately address the point you're raising without kind of tying us to historical points of reference that might be difficult to interpret today?
Well, I think a little bit more succinct to that is that there has to be parity reimbursement for, because it's for coded services, it's for services provided, right? We're all working off the same set. So there's a rate attached to that, whatnot, but that has to be for all people who provide that service. So parity service reimbursement. I think that would then eliminate.
So that's probably a separate recommendation we'd want to talk about here. Shane and Amy, for reference, Washington Medicaid does not pay the same amount of reimbursement for services to nurse practitioners and to physicians. And so that's what she's referencing. And there was a bill to do that last year that didn't pass. And I know it has been a topic of conversation for a while. And so I think that would be a separate thing that we could definitely talk about if we want to make that one of our recommendations. And I don't know if that's further in the set or not. Now I can't remember all the things we put into the slides.
Yeah, I don't think that is one that was necessarily singled out before, Judy. So it's not to say it's off the table. It just wasn't officially voted on as a group and elevated to the rank of our current cluster.
Well, I think, Maddie, correct me if I'm wrong, but I think Medicaid does, it reimburses like LNI, Medicaid, it is at parity reimbursement. It's the commercial insurers.
Yes, yes, yeah. That is correct.
Yes, you are totally right. Yes, I'm sorry. I did misspeak for sure.
Okay, so let's flag that we do have a discussion. We're going to have, I'm sure, a very robust discussion when we get to payment policy. I think we do want to pull out the principles that we're trying to adhere to. I've tried to capture that at least generally. So, and then if there's any disagreement on including this bullet, just raise your hand and we'll discuss it further. But we'll keep going here.
And Ginny, I think you were next in line for questions for principal commentary.
Thanks, Jean Marie. I always hate to add more words to an already long sentence, but I'd love to have something in that policies result in improved access, et cetera, about health or sort of population health. it seemed like it was missing, unless that's kind of inherent in the quality of care, but that results in better health outcomes for the people receiving that. And whether we want to consider experience as well.
I think those are interesting ideas. Do other committee members want to agree or not, or offer something different?
Great. Well, let's keep taking feedback, and if you do want to chime in on anything that's already up there, again, just feel free to raise your hand. Mandy?
So I had, so we mentioned up here clearly define action and actors. I just would like something around measures too, just clearly define measures. Right, policy measures are clearly defined, just something so that we're not, so we have our definitions ahead of time before we start actually looking at the data versus looking at the data and then creating our measures afterwards.
So it's there's quite a wide range of types of policies, so I want to make sure that we're general enough. So policy measures are clearly defined. We can unambiguously, so it's clear whether or not progress is being made in implementation of the policy. Is that
right? I mean, yeah, because we're talking about policies resulting in improved access, quality, health outcomes. You have to have all this defined ahead of time.
Yeah. And when we get to the detail, let's make sure that we flag that. I do agree, and I think that's part of the clearly defined actions and actors. So I like how you coupled it with that too. So
yeah,
it's a good call. Thanks, Mandy. Sean?
Sorry, Shane, I had a hand up from up earlier and I didn't put it down.
Oh, no worries, no worries. Okay. All right, so that's a good set. I think I'm gonna copy that. We have, this might be too long for where we're gonna paste it in the future, but we'll run with it. Does everyone want to take a quick look? Any final feedback? We added quite a bit too. So again, if there's anything you feel needs to be changed, please flag that. At the very core of it, just want to be sure that we have really clear policies that are doing good things, and that we know who needs to do what, and that we can communicate that. Like I said, the next step after we flesh out exactly what we meant with some of those earlier policy proposals is to hand it off to the state to start to flag issues and vet feasibility. So we'll definitely have a second crack at this. Okay, seeing no hands, let's move on here. So the strategy for refinement, I've already kind of stole my own thunder, if that's a thing. But just as a reminder, this is the framework that we've been working under. So rather than just looking at like a singular policy that, for example, mandates insurers to get to a 12% and then moving on, we've taken a broader approach. We're thinking about what does primary care need to be successful, and in this framework, direct investment is obviously key, but thinking about capacity growth, patient engagement, reduced expenditure on other services, that's not talking about rate cuts, not to make anyone nervous. That's talking about what Judy was referencing earlier, is that if we have the right care through primary care, we would expect to see reductions in exacerbations of conditions that result in hospitalizations, people showing up in the ER, that type of thing. So building on that framework, what you can see on this slide is the initial set of policies that were identified both by looking at some of the policies implemented in other states, but also things that were added by committee members. The numbers in the parentheses here, these represent the number of upvotes. In some cases that it says net, that just means that there may have been some downvotes for that particular policy as well. Our strategy for today's conversation was essentially take the policies that had at least 50% of the group expressing interest in exploring those policies, which is essentially through number 8 here. So capacity growth, multi-payer collaboration to implement payment models that offer greater financial flexibility and incentives while expanding access and improve quality. Everything above that's included in the conversation for the rest of today. There may be other policies that come up, and that's totally fine. As I said, the focus today is to flesh out as many of these policies as we can, get the feasibility analysis. And our next meeting, we're going to keep working on the policy set. So that could include, if we identify more stuff today, fleshing those out a little bit more in similar fashion to what you'll see we've done for these top 8. To try and chunk things out to make it a little easier for conversation, we've organized these the top 8 policies in that set into these general categories. They include multi-payer alignment efforts, provider payment level, so reimbursement, workforce, and patient engagement. I have one caveat about the content here today. So we've been doing a lot of background work since the last meeting to help come up with essentially straw proposals for more specific policies that are aligned with what you came up with in the last meeting. And one area where we still have more work to do is under workforce. So there are quite a multitude of efforts on the workforce arena. And we want to be sure that before this group puts in a lot of effort into developing more refined policies, that we've brought you the information to make informed recommendations. So more specifically, what I mean by that is that we want to make sure that you have a clear understanding of what's happening today in the state around workforce, so that your recommendation is really building on opportunity, as opposed to either potentially duplicating something that's already underway or even potentially contradicting some other efforts that might be underway. So we will still talk about changes to the non-compete under this workforce category, but we are putting a little bit of a pin in student loan forgiveness and the pipeline and education system conversation. We do have some context on other state policies and in Washington state policies, but like I said, it's such a big area. We want to do our due diligence before bringing those back to you for further refine. Had a couple of questions here that came up. Crystal?
Yeah, just quick question. If it's going to come up later, just redirect me. But on the workforce, I think one of the other areas of interest is those providers, those care team providers, clinical pharmacists, et cetera, who may not be, recognized as providers. Is that on the list anywhere as far as a policy for us to consider? Or is that one that's kind of lumped with the workforce that we're putting a pin in that?
I think that lumps into the pipeline piece there, Crystal. Sorry to cut you. Was that where you were going to go, Shane?
I was actually going to ask for a little bit of clarification. What is the specific policy around the ancillary team that you're getting at here?
Which provider or which credentialed types can be Medicaid providers?
Okay.
For reimbursement.
So that's not a policy that we've captured. I don't think that was actually even one that we voted on previously.
Oh, I thought I saw that with clinical pharmacists and the like. Okay.
However, we can talk about that a little bit later.
There it is. Yeah, it's that number 11. So essentially from 0 to something. Yeah. Mm-hmm.
It's not it. Thanks for catching that. I missed it when I was looking at the list quickly. So this is one where while we were voting, we had a net vote of 1 out of 14 members that supported it. So I think that there was 2 upvotes and 1 downvote for that. So I don't know if other committee members wanted to discuss this now, or if maybe what we can do, why don't we carve out, I don't know, maybe 10 minutes towards the end of this meeting, and we can do a quick inventory of policies that for whatever reason didn't make the cut, or that are new policies that come up as part of this conversation, where the staff team can go back, see what's happening, see what the current state policy, and bring it back similar to the policies we have fleshed out. And we'll make sure to add that one to the list for discussion.
Sounds good. Thank you.
Okay, absolutely. And Tony?
Yeah, so this might actually be linked to Crystal's comment. When I look at this list and it talks about increased primary care reimbursement, I don't know that I expected to translate directly to the slide we were just looking at that seemed to just talk about reimbursement to the primary care providers. Because I think if you talk to most people providing primary care, there might at times be concerns about reimbursement to themselves, but I think the bigger issue is their ability to care efficiently and appropriately and holistically to our patients. And I think that most of the time when we think about increasing primary care, it means that we have a better EMR, we have more team members, more people to help us room and take care of patients. We might need integrated behavioral health. I think every individual and every system might be different. But the first one on the other list, to me, I would consider much more broad and would actually incorporate the things down there in number 11 so that we get those teams assembled. It's more than just paying the physicians and nurse practitioners and mid-levels. It's really building up that team of services. So I don't know if that's a perspective that registers with others, but I just wanted to offer that.
Well, I think that's a great comment. So how about this as a proposal? When we get to the payment section, which I think is first up, we'll have draft proposals of more refined policy. What I'd recommend is that you help us refine that draft policy statement to capture whatever definition of primary care needs to be there in order to achieve what you're talking about. So we can use the policy statement refinement discussion to really capture that concept effectively. Hopefully, we'll give it a good go if nothing else. If we need to have multiple policies, we can look at that too. Other comments before we move on? I think we got all of the questions that were queued up. Great. Okay, and we already talked about this, so we'll work on the policies today. HCA and potentially other state agencies as appropriate. We'll do a review for feasibility, red flags, that type of thing, and then we'll continue this conversation in additional depth before asking you to vote on a set to advance back to the board. All right, so to the policy, the first set is the provider payment level. We've used a similar framework to tee all of these up across the different categories that were on that prior slide. We'll essentially flag the specific these specific policy recommendations. In some cases, we've made pretty minor tweaks just to delineate across these specific recommendations where they potentially overlapped. After that, we'll look at what the voting was on each of those just as a point of reference. That'll be brief. We'll verify that there's a connection to the 12% primary care expenditure target. We'll run through a little bit of context that will typically include, where appropriate, what the status is in Medicaid, like how things look today, if it's relevant for Medicaid, and then also examples from other states to see how they implemented policy that's aligned with the recommended policy. From there, we'll go into looking at a couple of straw proposals for the policies. We do have, we are trying to keep top of mind some of the principles. I'll try and pull those back up while we're talking about it to make sure that we're on point. But we'll really spend the majority of our time talking about how we refine these specific proposals. So for provider payment level, increased Medicaid payment was a specific policy. And then encourage overall increase in primary care payment across public and private payers. So we made that slightly more general than the original statement, which you can see here. So increased primary care reimbursement, which we'll have the opportunity to unpack that momentarily. Unambiguously, I mean, the reality is that this set of policies really is getting at your core charge. It's just, again, that we do want to use this opportunity to make sure that we're recommending policies that create an environment where primary care can be successful, not just the direct investment. So, but again, this really is kind of the meat and potatoes of the charge of the group in terms of driving policy to get to the 12% target. So there's clearly a connection there. Passes that test. To provide a little bit of context around how things look today, this also, we've tried to give context on how things work a little bit. And the idea is that helps you understand, well, who is actually going to have to take action in order to implement these policies. So this first section for Medicaid, we're just flagging that changes to Medicaid reimbursement will typically require legislative authorization of funding to support increases. The federal government pays a significant portion of Medicaid's funding, or contributes a significant portion of Medicaid's funding. So there's a whole process by which the federal government has to approve increases in reimbursement to specific provider types. The Medicaid system is largely administered by managed care entities in Washington. So there's contractual obligations, or there's a contractual processes that would have to be implemented in order to effectuate these changes. And then just by way of context, this is both, one, a little bit dated, and two, it's unclear how accurate the methodology was, but hopefully this is a good sense of benchmark. But the Kaiser Family Foundation reported that 2019 Washington Medicaid reimbursement for primary care services were in aggregate across services approximately 63% of Medicare. I don't know if that's aligned with some of the earlier statements around where you're at for reimbursement, but that was the most recent data point that was reported through KFF. The examples of public policy that incentivize increased payment rates for primary care. So this is where you're really getting to some of those 12% policies in other states. Rhode Island, they've really been a leader in this area. Their policy essentially required commercial insurers to approximately double primary care as a percentage of total spending over 5 years, without causing overall spending to increase. We'd note that the insurers were actually successful, and the policy then evolved into a requirement to maintain the level of primary care spending. This was essentially effectuated through the Office of the Health Insurance Commission. I think what's really important to note across these three different state examples is that they actually use three different mechanisms for these policies, and you can think of it a little bit as each mechanism has a different level of teeth to it. So the enforceability and the difficulty to implement is going to vary too. So, really hone in on these three examples because they're going to be important for our conversation. The second type of state policy, it's a bit of a twofer in that you have both Pennsylvania and Connecticut that implemented similar policies. They set 5-year voluntary annual targets to increase primary care spending. It was done through legislative action in one and through an executive order in Connecticut. Oregon, they required health insurance carriers and CCOs to allocate at least 12% of their healthcare expenditures to primary care. So they did that through statute. So we started with two policy proposals. One was rather Medicaid centric and the other was broader. There's already been some discussion around the intent of investing in primary care and how maybe we need to be interpreting that a little more broadly. But we've taken a stab at drafting policies that could be implemented that are more specific. It's clear who the actor that would have to do the thing is. And we think that they generally adhere to the initial set of policy principles that were introduced. So here's where we're going to open it up. And this is your opportunity to, based off of your perspective and the conversations we've already had, how would you recommend refining these policies? So the first one, the legislature should fund increased reimbursement for primary care practices and services covered by the Medicaid program, with the goal of achieving a reimbursement level of no less than 100% of Medicare by 2027. The second one, the legislature should pass legislation mandating commercial and public payers to allocate at least 12% of expenditures to primary care by 2029, with interim goals informed by committee analysis in 2024 based on the primary care expenditure measurement efforts. So this is more like the Oregon model. We have a little bit of hedgy language in there because we don't know where we're at today until we haven't applied the definition that you've developed to where we could set, incremental progression marks. So we have some placeholder like language there. So committee members, where would you like to start? Jonathan?
I really like these. Thanks so much for putting these together. The first bullet point surrounding Medicaid. My first review, I think mostly with a fee-for-service mindset in how I read this, but especially since we're moving towards population-based capitated payments anyways, and since the Making Care primary model is also moving towards this payment and is intended to be multi-payer, it would be great to make it explicit in the bullet point that we mean not just for fee-for-service payments, but also for non-fee-for-service payments. To have parity between Medicaid and Medicare reimbursement. So I would say maybe because the way it's currently structured says primary care practices / services, and services makes me think of fee for service. So maybe some mention of caring for individuals or for populations at parity.
There is this concept of a fee-for-service equivalent. So if you create a capitated payment based off of the services that it's comprised of, you can calculate what the fee-for-service equivalent would have been. I've seen in multiple circumstances that fee-for-service equivalent is used to help establish baseline pricing levels when you're outside of fee-for-service. So now we're saying, so the Medicaid program with a goal of achieving a fee-for-service equivalent reimbursement level, regardless of the payment mechanism or payment model mechanism of no less than 100% of Medicare by 2027. Does that
work for me?
That work? Okay, great.
Thank you so much.
DC?
Hi, Shane, DC here. Sorry, I actually have a question for you rather than a suggestion. Are you able to comment, and thanks so much for the summary of the different state approaches. Does anybody know whether those have worked? I mean, do the individual states think they did the right thing, or do they not have enough experience to make a judgment about that?
Well, I can tell you, and Judy and others that participated in the call, I think it was with Milbank. We do know that in Rhode Island they hit the targets, but we've been meeting with I think it's their interim insurance commissioner there, and they're making some refinements to the policy. I believe it would be an accurate assessment to say that it's been successful, that the insurers have hit those targets, but that I think there are probably both operational and policy considerations that are driving some, refinement of those policies.
Actually, what I was getting.
Oh, yeah, go ahead.
Well, I was going to say what I was getting at is has the health of the public improved? In other words, that's what I mean by work.
Yeah. No, that's a better question. I don't know the answer to that. Okay. We've actually been talking about trying to get a hold of either Rhode Island or Oregon to have them come speak on how the policies have played out in practice. And we can, I think we're going to see where we're landing with how much content we need to get through with the group. But to the extent that we're able to, if we're not able to do that, at a minimum, we can try and reach out and ask questions like that for you. So,
Okay, great. Thanks.
yeah. And sure.
Am I off mute now?
You are, yes.
Yeah, okay, thank you. Yeah, thanks, DC, for clarifying. I had the exact same question, so thank you for answering it first. And then I guess my question specifically around, if you can go back, Shane, to slide 17.
Yeah.
Yeah. Do we know how far off we are from 100% of Medicare? Because I do believe, at least with the some of the peds preventative care increases, that we're pretty close, if not there, on some. It is my understanding. So I guess before I said, yeah, that's what our goal should be, I'd kind of like to understand what it is right now, because I think it's close in some, and I don't know how far away in the other, to know, would that alone be a big enough difference for us to get us where we want to be?
I'm really glad you asked that question. That teed up something that's been kicking in the back of my mind, which I'll come to in a moment. But the data point I have, it is a little bit dated. It's 4 years old. I guess that's not terrible, but the Kaiser Family Foundation was reporting that in aggregate, the Medicaid reimbursement is around 63% of Medicare. I don't know if anyone on the HCA team has better insights on this specific thing. I don't know if there's been a study conducted other than this one internally to answer that. Sorry to put you on the spot.
Yes, this is Judy, and it is true, Cheryl. I think we're pretty close to 100% for pediatric services, because there have been a couple of pediatric specific rate increases over the years, but the rest of it, I think, is pretty close.
Okay.
To that amount. I want to say that the number that sticks with me is 65%. But we could get you better numbers if that's of interest.
No, I mean, if we're still that overall for my colleagues, if we're still that far away, absolutely, it feels like that's a significant difference. And then I guess my question then specifically around peds is what led to us having increased rates right now, quote, permanent? You know, I know nothing's permanent, but do we have to, I don't understand the legislation that led to it enough to know, is that at risk or not? So that, and you don't have to answer that right now, and we can follow up on that. And then I have more and more wondered about this, and I've said this to Judy and others, that we have two classes of public insurance in our state. Those of us who are public employees have insurance, myself included, from the state, and then Medicaid is state insurance, and the reimbursement rates are extremely different. And I find that interesting for a state so focused on equity. So I wonder if there is some opportunity somehow to think about aligning better those two classes as a component of the mechanism to get us where we want to be around primary care. And has anybody else looked at that in any other state? Because it's interesting dynamics at play, I will say.
I think that's what I guess you had a few questions in there. In terms of across other states, it's not universal, but it's probably pretty close that Medicaid reimburses lower than even other public payers, which are typically closer to commercial. And there's a lot of reasons why. The underlying revenue streams, employee contributions, how Medicaid, the kind of set and forget unless there's legislative action to make increases, they all serve as barriers to keeping up with the time, so to speak. My question for you is whether or not there's something specific you would modify about the recommendation here, or if that was something for the group, just to kind of get some foundational knowledge to give us some directional insights on the existing policy listed here.
Well, I do wonder specifically if there, well, maybe this is a totally separate and shouldn't be in that maybe, you know, maybe this is other work, honestly, Shane, but you do wonder if there should, maybe it is different work, if there should be that the two should never be X% different from each other. I do understand there's tons of other drivers, but it's a terrible system that we have. I mean, I feel very uncomfortable as a beneficiary of having good state insurance. It is not lost on me that I take care of Medicaid kids who are state insured, and I'm state insured, and my state insurance for my kids is a hell of a lot better than for my patients. And my kids need it less, and the Medicaid kids need it more. So it's not, I do wonder if it probably, I mean, it's related, but potentially, maybe I just talked myself into, maybe it's just another pain point in the system, but it's a different body of work potentially.
The other thing that the other thing that kind of stuck with me when thinking about the draft proposal here is that, you know, these percentages are in some regard a little bit arbitrary. Like, yes, it's more, but is Medicare reimbursement the right level of reimbursement is kind of the underlying question. And I think the reality is that it's going to depend, because you have a variety in provider scale, which is going to impact cost, and provider, you know, sophistication, which could impact infrastructure cost as well. It almost made me wonder, like, is there a way to get a sense of the provider cost of doing business, and that reimbursement is adequate to cover that without introducing something that would be absolutely crazy making for providers to get at that information? Just wondering if anyone had any thoughts or insights on that, because that seems like it's really at the crux of what is the right level of reimbursement, which these percentages are really guessing at, just to be blunt. Katina?
Yeah, Shane, this is Katina. I'm not sure that anybody is really thinking that Medicare is the standard that we need to go to, but it is a standard, and that it's better than kind of no standard. And I wanted to really echo what Cheryl just said, and that was, I'm still trying to take it all in, and that was really profound, that in a state that talks about equity, how inequitable the state reimbursement is. And it's kind of hard to swallow, really, when you think about it. So that would be maybe an aspirational goal, to get Medicaid up to other state reimbursement levels, perhaps. I just wanted to say thank you, Cheryl, for pointing that out, because it's really important to acknowledge that.
Your state, I think, is, I'm trying to remember specifically, is it around 20% of your population that is in Medicaid? I just don't know that off the top of my head here.
Well, 50% of the kids in the state are on Medicaid.
50% of kids. All right, which
adults, I don't know as well. I don't want to talk if other people have their hand up, Shane, because I want to give other people a chance.
You were the only one at the moment.
I guess I was just going to respond to your question about what is the right Oh, somebody, oh, isn't that nice? It automatically lowers my hand for me. So I was just gonna say that, I don't know if this, I will say, I don't think that probably 100% of Medicare does cover the expenses. I will tell you that I know like the Children's Hospital is in the hole by tens of millions of dollars for the year, and will finish in the hole. And we have 2 practices closing their doors in our network because their reimbursement rates are not enough to keep them operating. So I do agree that I think even if we got to 100% of Medicare over time, that's not enough. It's not the right target, but it sounds like we're pretty far from it right now. So it does seem like it's a reasonable place to start. So I will agree with Katina as a starting place. It does seem like a reasonable place to start.
Are there other policy refinements for this statement then, given this conversation, or other thoughts that you may have? Ultimately, the question will be, is this a policy that you would want to advance to the board, assuming, that once you get more information on general fiscal impact, feasibility, that type of thing. Tony? Tony, did you have a comment? No. Okay, Jonathan.
Hi, yes, sorry for the delay. I didn't want to be another silence, but I would certainly be very much in support of this. I think of all the policies that I read through the slide deck, this is the one that most resonates with me. I know that we're going to be talking about others as well, and I think one exercise that might be helpful moving forward, to the extent that it's possible, is I know that we're aiming towards getting towards 12% per the statute. It would be great if at future meetings we could have, a ballpark back the napkin guesstimate of, if this policy were implemented, let's assume we're currently at 5%. The Medicaid policy we're discussing now would get us towards primary care at 9%, some sort of almost like a progress bar of, we're currently here, implementing this gets us here, to help sort of triage and prioritize which policy suggestions. I know that will probably be difficult to operationalize, but to the extent that it's possible, sort of knowing a price tag for each policy proposal might be useful. Thanks so much.
Yeah. Thank you. That's definitely top of mind as we're looking at as we're going to this next step of state agency review. They can both verify that our starting positions are truly accurate based off of current state, and then that will allow us to look at, well, what does closing the gap to the policies we refine mean? And I wish we could have had that for you today, because it might help your thinking around the actual magnitude of the policy. But it's an excellent point, so thank you for raising that. Tony, did you want to take a second crack here?
Yeah, this time I'll try to remember to unmute myself, sorry. So I think my question on the Medicaid reimbursement is partly practical, partly political perhaps, or I just want to make sure the groups behind doing this just for primary care services. Certainly our subspecialty colleagues would say the same things that we are, and we've all had difficulty finding specialists to take care of our patients on Medicaid. So as a 12% committee, I think that fits, but it's possible it's a separate discussion where we link arms with our specialists and try to get Medicaid up to 12% for everybody, which doesn't do the 12% any good, and make that a separate issue. So I think that was my only comment there.
And in full disclosure, that's the exact type of thinking that we were trying to highlight with the potentially competing other stakeholder groups. The reality is that it's a publicly funded program. Medicaid is a publicly funded program, and that requires appropriations. And it's not just a competition for the limited funding within healthcare. It's across education and every other public program in the state. And it's, that's the hard thing about public policy, because these trade-offs can be really brutal. So, this is this is one of those areas where the political feasibility is going to be one where I think it'll influence maybe once we get the fiscal impact, thinking about, well, what is the time horizon for getting to that target, that type of thing. But it's such a great point. Thanks for raising it. And then also keep in mind, it really is competing with every other dollar that's spent on education and other programs as well. Meg?
Oh, thanks. I'm not quite sure how to word this, but I think we need to be cognizant and maybe explore a little bit further, perhaps, if there are resources available through Milliman, since they do the rate calculations for the program, what it would need to look like so that the providers actually felt that they were seeing increased funds in their pockets as a result of whatever program we put into place. I'm thinking of the reaction when the legislature appropriated funds to enhance behavioral health payments, but because of the way the rates were blended and structured, the providers themselves felt that they weren't seeing the benefit of that allocation or that appropriation. So we just need to make sure it's whatever we recommend, it's structured in a way that meets the expectations of the provider community.
Yeah, there's of course, Medicaid policy is complicated, but there is a tool within Medicaid where the state can be directive on it. There's limited circumstances in which you can apply it, because CMS does believe that when you've delegated responsibility for financial management to managed care entities, that they need to have the flexibility to negotiate and to actively manage the system. That said, the federal government provides a mechanism called a directed payment, which can allow the state to be more prescriptive on reimbursement rates in some circumstances. So as part of the feasibility analysis, we'll flag your specific concerns. So ensuring increases actually flow to primary care providers. But the point being, there may be some practical solutions that can be identified on that front.
Yeah, I mean, and this committee, I don't think has the expertise to make specific recommendations about how to structure it, but I think that it's important that we be aware of expectations versus how it actually gets rolled out.
Okay, thanks very much. And Tony, I see your hand is up. Was that a residual? Okay, and Meg, you too. Did you have an additional comment? No. Okay, I chased you off. Sorry about that. All right. Any other refinements or comments, things that we need to be exploring as we prepare to bring back more information to you, Michelle?
Yeah, I wanted to just talk a little bit more about the timeline, especially on the second bullet regarding commercial payers and getting to the 12% by 2029. Just, again, looking at, I represent United, so just kind of looking really high level at some of our information. I mean, it would be, I mean, it's going to be a huge lift to try and get to that point without adding a lot of cost into the system. So the only other way is to, to reduce services in other areas. You increase primary care and hopefully you're reducing hospitalizations, whatnot. But that takes a long time. So I wanted to know, first of all, are these timelines dictated by any legislation, or is this, we can give a proposal for a timeline? What is the ask there?
Yeah, I think you have the flexibility to dictate the timeline based off of where you're at, where you're trying to get. Looking at the historical analysis from OFM, we don't know how different your definition will be, but we're talking really big numbers here, so it probably won't be too big of a shift, but I think it was around 5%. So you're talking about a 7% shift, which is non-trivial. But what I would point out is that that's almost close. It's relatively close to what Rhode Island did, and they achieved that in 5 years, and they actually achieved it. I think going from 5 to 12 is a little bit bigger than that. They approximately had to double, and this is 250%. So what would you propose modifying that to, and do other committee members have a reaction to that?
I mean, I think it's hard to pick an exact year. I mean, is there any way we can try and give the recommendation that year over year we continue to see increases, so we're working towards the goal?
You sure can. If that's the direction of the committee, I think there's going to be pros and cons to that. So the unambiguous intent of the legislation is to drive towards the 12%. And if I think if you have a recommendation that's incremental progress, you'd want to structure that in a way that you're seeing real progress over time. So that you're actually meeting the charge of the committee. But I think you do have flexibility on how you do that.
I like that idea, this is land. And I think as we learn from other states, right, as we gather feedback from others who have done this before, then I think we should leave it open and have the ability to pivot if needed, right? As long as we are seeing value to our providers and to our patients.
This is Judy, and I think Oregon had a goal of increasing by 1% every year as how they started. So that's another example of an incremental way.
And Cheryl, you have a question?
No, I have feedback on
Comment?
the
Yeah.
recommendation. Yeah. I probably will have to sleep on it and think a little bit more, honestly, before, I don't know, are we expected to vote on this today?
No.
Okay, well then, but I really at face value, I like having a defined target at a defined date. I will say we haven't had rate increases on the commercial side out in independent care land for years and years and years. And I just worry that the things that are the factors already at play preventing appropriately funding primary care will just continue if we don't draw a line in the sand with a number and a date. I just worry about us achieving what we really set out to do if we take a different approach.
So we can, I mean, if we do adopt the 1%, I think the point is if you're adopting a percentage increase annually, that you'll be able to define your target, obviously, just by whatever the gap is. So if you went with the 1%, similar to how Oregon started out, that would have, super rough numbers here when we need to get the actual new definition number that would put you around 2032 to get. So you'd have both pieces, the incremental annual and the 12%. But it would be by 2032 instead of the straw model of 29. Okay, other comments?
Erin, comment from you?
Yeah, thanks. I absolutely agree. Having clear definitions are essential when you're going to the legislature and asking for guidance and direction. I think just having it specifically laid out would be very helpful.
Okay, so does this middle text in red start to strike that compromise sufficiently? Sean?
Yeah, I feel obligated to say that if primary care were a patient, they right now would be on life support. And I think I heard an executive compare primary care to global warming where we've kind of blown past the inflection point. So I don't think this is aggressive enough. I think we'll be in really bad shape if we shoot for 1% a year. That's my opinion. I would advocate for 3% annually or something a little more aggressive.
And to be clear, like we're just the way the math works out, right? So you have like a 1% isn't going to translate to a 1% increase in primary care reimbursement rates necessarily, since primary care makes up a small percentage, or not a small percentage, a smaller percentage than the combined other service categories. A 1% increase in the percent of total could in fact be, or a 1 percentage point shift could be, you know, a 5 to 10% increase in primary care reimbursement. Given that in mind, is that still consistent with what you were thinking when proposing a 3% target, or are you suggesting that a 3% rate increase would be necessary to keep primary care from totally sinking?
Yeah, thanks for the context. I wasn't really maybe following the math as well. I guess my point is, I think that there's some urgency to acting, and that's what I'm trying to articulate. Thanks.
What we can do also as part of that the next round of vetting with the state is we can go back to, since we won't have an updated calculation for under the new definition, we can look at the prior definition and see what a 1% increase in primary care looks like from a percent change in increase in reimbursement. That's still going to be a little bit back of the napkin because it's not the only factor that feeds into a very complex healthcare system. But I think it will help ground, you know, what does that 1% even mean when we set it as a target from boots on the ground, what a practice could expect to experience. And I think that would be really helpful. So I think it's great that you raised that question, because that leads us to being able to make a more informed policy.
Great. Okay.
Yeah,
thanks,
I'll just second Sean's life support. And I don't know if anybody really realizes, it is really dire out in primary care land. And I only know the pediatric environment, but it is really bad. Physicians are quitting. We can't hire staff. The rates, you know, what the inflation, everything, the cost of everything went up, but the cost of what physicians are getting reimbursed has not. I mean, it is really bad out in primary care land. For anybody out there who does not realize that, it really is. And I agree with Sean. I think we need to be more aggressive.
What would you propose? And then how do other committee members feel about that?
I mean, I would do, so I will have to agree with Sean. I don't understand what 1%, what that, you know, I don't understand that, what that means, what that impact would be. So I think in order to give a really well-informed recommendation, we have to understand what that means. But it's the 2032, I think it's too long. I mean, I love that Rhode Island said in 5 years, right? If I remember.
Yeah. That was to essentially go from 6 to 12, and I mean we'll see where you land, but we think you're around 5% currently. It could be 6 though. We'll see. But the point being that that's in the ballpark.
Yeah, and Cheryl, I just wanted to add on. I mean, so part of what the internal vetting between this meeting and next will entail is getting to that kind of question on an internal level, because sure, we can look at Rhode Island and say, great, they did it in 5 years, but we're not necessarily coming obviously from the exact same resources and framework that they are. So I understand the urgency, but we also have to assess from our current status of Washington State. So we'll certainly get back to you on that with more research among our staff and other agencies that we communicate with.
Madeline?
Yeah, I put my hand up right before, was it Sean, I think, who started saying what he said, and then Sheriff said what she said. I just want to agree with all of that. I think it's very, very urgent. I'm from a primary care small practice, and there's a couple reasons why we're still alive, and it is not because of insurance reimbursement. If Rhode Island did this, and they did it at a little bit faster rate, like you said, we don't know that everything's equal. I think we need to look at a way to make this happen as quickly as possible in general.
I don't mean to put you on the spot, but Michelle, does United serve in Rhode Island market?
Yeah, but I would not be familiar with any models that we might have in place there.
Do you think it would be possible to maybe for our next meeting to bring back what the insurer perspective was in trying to implement that?
Yeah, yes, I can do that. I can do that.
I think that'd be really cool.
Yeah, so I can find that out. The other thing though is the 12% just going to apply to just Medicaid and commercial, because we really can't control Medicare, right? So we're just putting, this is the 12% is, I don't know if that's actually defined or not, because are they expecting 12% of all expenditures, which means commercial and CAID have to make up for Medicare because we can't really control Medicare?
I believe Medicare is excluded from both the numerator and the denominator for that exact reason, but I'll double check. Does anyone else on the team know off the top of their head? Okay, we'll verify that for you, Michelle.
Thank you.
And Sharon Brown?
Thank you. And I just want to reiterate that the situation is particularly dire, and the legislature needs to understand how dire the situation is. And it's unfortunate that I'm just going to draw an example with some of our hospitals. Some of our more rural hospitals had to actually close their doors. And now there are residents that have no services, particularly in OB-GYN in the lower Yakima Valley. And it took that drastic action for the legislature to understand how dire that situation was. And I would hate to see this precipitated to that level. And I think that it's incumbent upon us to really tell the story about how dire a situation it is. And we don't want to have additional primary care practices have to close their doors, because that's just going to end up flooding the emergency departments, which is what we're trying to avoid. So I think we really need to kind of come at this pretty strongly and really help to educate the legislature about how dire the situation is.
I think this is a really helpful point that you're raising. I know that as part of some of the multi-payer work, we look at, well, how do you create the case for additional investment in primary care, for example, and looking at messaging and whatnot around that. We know, like one of the more recent sources of information that starts to paint that picture was a recent Alliance report, and it doesn't, from my recollection, it doesn't get into the type of anecdotes that you're referencing of individual providers closing whatnot, but it does highlight how outcomes are in decline, how there's 3.5 million people in a healthcare shortage area in Washington. It does start to paint kind of that population picture. But I think that these individual anecdotes, to your very specific point of that's what it took to get the attention of the legislature, I'm wondering how we could start to collect and coalesce some of those examples and anecdotes so that we can paint the picture. Because ultimately, it's not just the policy that, it's not just these policy recommendations that, then go into a report and then go to the legislature. If there isn't a sense of urgency that paints that picture, then they're just recommendations in a report, right? There's no guarantee of action. So I think that to the extent that you passionately feel like there is a true crisis here and that these are true solutions to help remediate that crisis, we need to paint that picture. So I think collecting those anecdotes, in addition to what I think they're useful, but I think limited in those really like powerful, this is what's happening in your community type anecdotes, it won't be enough. So I don't know if, I'm not sure what the process is by which we start to collect that, but maybe we can discuss that with HCA and with you all and figure out a plan of attack there. Jonathan?
Hi, this is a request for next meeting. I really appreciate the comparisons to Rhode Island and really admire what they did, having gone to medical school and in Rhode Island when this was occurring. In addition to what they did, I think it'd be really helpful to know how they did it. I know that they have the Rhode Island office of the Health Insurance Commissioner's office, and I believe vaguely that they had the power of rate review as their way of enforcing the gradual increase in primary care expenditure. I genuinely don't know what enforcement measures we would have in place with the General Insurance Commissioner's office, which I know covers health insurance, but also other forms of insurance in the state of Washington. And so in trying to mimic Rhode Island to the extent that we would like to, it would be great to know an apples to apples comparison as to what regulatory tools they had that we don't, or that we have in common, to know how to make an action plan around implementing the increases with insurers. Thanks.
Great point. We will sink our teeth on that and bring back some more information. Tony?
There we go. Thank you. So 2 quick points. One is echoing Shane, great comments and the urgency and the comments that came from that. And what I want to say in that regard is that the legislature last year did not hear enough from all of us about this sense of urgency. And I think that gave them kind of a window to just give this issue a pause. And we need to, all of us, go back to our professional organizations, the societies, the areas of influence where we have a voice and really kind of collectively bring that sense of urgency going into the next legislative session. So this is first and foremost on their mind as well as governor's office and stuff. So I think that's one. The other is when we talk about future investment, I think that I'm hearing a lot about fee-for-service reimbursement for providers, but I think future reimbursement or future investments will largely and should largely be in non-fee-for-service, claims-based, per member per month, more flexible. Those kinds of reimbursements really need to be explored. It's more challenging to measure, but it's actually more direct to providers and expands the team-based care and stuff. So I think we and the legislators, the payers, the insurers, everybody should be thinking along those lines and working together in that realm more so for future investments. Thanks.
And that's perfect. And we've folded that in a little bit into the multi-payer alignment, in part because it would be a little bit crazy making for providers to have 20 different types of payment arrangements, even if they're all towards that more noble goal of having greater flexibility. So we will definitely have the opportunity to start fleshing out that policy. Again, I know that this particular set of policies, really the second one in particular, really is getting at the core charge of this group. So this was an absolutely valuable use of time to start to flesh that out. We clearly have more opportunity to get more information, to answer some really specific questions to help refine that policy. Just to highlight again, as a bit of a recap, Michelle kindly is going to see what the insurer experience was like in Rhode Island and trying to implement on a relatively rapid cycle. Just to give their group some context, we're going to do some math on some of the OFM reporting in the past to help illustrate what exactly does a 1% increase in that ratio look like in terms of an aggregate increase or a percentage increase in primary care reimbursement. We will come back with some information on the specific mechanisms by which you enforce some of these policies. And we'll also see if we can get some additional information on the general efficacy for driving outcomes as a result of setting these primary care targets in other states. Some of this other stuff we'll have to work on together, but those seem to be the key pieces for further refining this policy until next time. Is there anything that is missing that's still, stuck in the back of your mind here that this is kind of the big one to get right, of course. I mean, it's all important, but is there any other piece of information that you think would be critical for being able to come to a pretty concrete recommendation that you feel would be essentially address the crisis at hand, but also is, realistic? Linda?
Yeah, thanks. It's just me reiterating the idea again about where we're starting at. It's an even playing field regarding the expenditure to be the same, right? And for the provider providing the services and for the care being delineated. And I'm in complete agreement because I live in primary care land every day for a lot of hours per week. So in regards to that date, which I know is there as a placeholder for further discussion upon getting further information, but this this idea about allowing such a long drawn out part to get to a point where actually there's going to be some effectual changes in our capacity for care delivery and providing access. I think we just absolutely have to drive that date down. I mean, to where it's realistic. So the one, you can disseminate the information and people can align. But if you ask if the insurers are interested in understanding where we in primary care or in other practices would say, hey, if you want some ideas on how to make sure that you can reduce from one part of your business model to a different in order to address the primary care piece, there's plenty of ways to streamline that interaction. So and that's what I was hoping, that part of this, as we go through this whole process, we're looking at that whole process of primary care and primary care delivery, right? And so there's lots of places where if people are worried about where that money in the budget is going to come from, besides the downstream effects, which is keeping people out of the hospital, keeping them healthier, keeping them with less disease burden. But beyond that, there's other things that inherently are part of our structure that eliminating, reducing, or streamlining already gains you too. So I'm all for making sure we drive that date down and making sure that in here there is an absolute, because an increase in reimbursement for services provided by me, again, as a primary care nurse practitioner, is not the same amount as a primary care physician by the commercial insurers in our state.
Thanks for that feedback. I think one thing that's important to note too is that like the NPs should be falling under the definition of primary care provider to some extent if the particularly on aggressive timelines, if commercial insurers, which you specifically called out here, have to get to a 12% target using a specific definition, and if the nurse practitioner is included within that, there would be some incentive to drive increased reimbursement there too. I realize that that's kind of an underlying incentive and not an explicit call for parity, but I do want to call that out, that the overall model does have some incentives driving in that direction. That said, if this group would like, we can modify this to include parity across providers as well. I think we're just going to need some more discussion on that. What I'd recommend, given that we have about 20 minutes left here, is that we put a pin in further discussion on the actual reimbursement or the reimbursement levels we move on to the next section, and we don't have to get too super far, but I think that covering some of the context and teeing some of the concepts around multi-payer alignments, and which really gets at payment models and some of reducing administrative burden and figuring out how to invest outside of service reimbursement as well, like through the Making Care Primary initiative, how those intersect with this policy in a meaningful way, so that when we do come back next time, we're all starting from a little bit rounder of a perspective, or a more rounded out perspective of how these levers can actually play out. And there may be some policies that come out of this that are really honoring those intersections in a meaningful way that'll help address this crisis. Like even if you can't go so for example, even if you can't make an immediate jump to the 12%, if you are offering more financial guaranteed revenue streams to improve sustainability in the very short term, that might help. And there's going to be some dynamic between these two things. So I don't want to cut any additional comments short or anything, but is that all right with everyone if we move on to the next section, and then we'll continue this armed with a little additional information in the next meeting?
Sounds good to me, Shane.
Okay, perfect. Thanks, Sean. Okay, so multi-payer alignment efforts. We pulled 2 of the top 8 recommendations into this category. So one is really around administrative burden reduction, and then the other is around payment approach alignment. The 2 specific policies. The first one that got around half of the group's interest, I guess is how I'd say that. Multi-payer collaboration to develop and implement payment models that offer greater financial flexibility and incentives while growing access and improving quality. And then focus of the payers on reducing administrative burden and costs for providers. We put out some arguments for why this is connected to the 12%. It really is, a couple of things just briefly. It's how do you use the resources you already have more efficiently by reducing administrative fragmentation? And then 2, the payment models offer as similarly using what resources you have more efficiently, but they also can contribute to increasing reimbursement in primary care. In context, so I think many of you know, because you have participated in some of the development efforts for some of the multi-payer collaborative and the primary care transformation models, but there's been a lot of work done in Washington on the multi-payer front, and kudos to Washington for doing that, because it's brutally difficult work, because while conceptually everyone is wanting to advance, wanting to do well for their communities and making sure that people have access to care, you have different business structures, and at the end of the day, they're competitors. So to come together and work together is just hard. But ultimately, there's been a lot of progress. So the multi-payer collaborative in Washington has developed the primary care transformation model. It really focuses on aligning standards so that, again, you're not fragmenting focus, you're trying to reduce administrative burden, alignment on quality metrics, same rationale. Practice supports, multi-payer strategies around practice supports to make sure that people have access to things that are going to reduce their administrative burden, help them be more efficient, that type of thing. And then ultimately, payment models for primary care practices. The next major step for the multi-payer efforts, there's actually a provider learning cohort that'll be kicked off later this year. The focus of the learning cohort is really to identify opportunities to support the practices in working towards developing greater competencies and ultimately towards participation in the primary care transformation model. The primary care transformation model has components around investing in practices to build infrastructure, so kind of this transformation payment concept, There's a core idea in it of moving towards more of a population-based payment with that guaranteed revenue stream, which should, at least in theory, really help with that sustainability argument. And then, of course, there's quality incentives. What I would note is that there's been relatively recent federal action. It's been noted a couple of times in this meeting already, but there's the Making Care Primary Care Initiative. This initiative, it's intended to be an aligned multi-payer approach. And it's bringing in additional federal investment in primary care practices. So there's upfront investment in infrastructure. There are, frankly, ginormous quality incentive payments for some of the more advanced providers. It has a very long time horizon for impacting the delivery system, so sustaining that additional reimbursement over a 10.5-year period. So it could be a really big deal. But what this means is that the multi-payer collaborative, in order to not just build a competing separate model that isn't well aligned, that group is working to figure out how to align with the Making Care Primary Care model in a meaningful way, so as to be able to tap into those additional federal investments while having models that are well aligned. And kind of the key thing that's really important about that is that ideally that's going to mean that you're offering these population payments to practices, and you're doing it such that multiple payers are offering that same payment, and practices will get to a critical mass of, so rather than having, just your Medicare patients in a capitated model, instead it's across a greater percentage of your panel, which means that guaranteed revenue stream, or that predictable revenue stream, is a bigger chunk of your business, which allows for a lot of different things, from not just sustainability, but allow for a redesign of care models that are not just the hamster wheel of fee-for-service. So honestly, a huge amount of effort to date through the multi-payer collaborative, tremendous, huge opportunity with Making Care Primary, with federal financing and different payment models there. And the two are working together to figure out intelligent solutions for Washington. And it could be a really make it or break it opportunity of, a combination of investments in primary care, but also paying differently on a big enough scale to really hopefully get primary care practices heads above water. So that's the context. And a lot of that, let me just pause briefly. I know that there were some questions earlier. We could do some quick questions here. We only have about 10 minutes, but any high level questions about these efforts to date, and hopefully in the back of your mind, you're starting to think about, well, what does it mean to have payers pay differently while we're simultaneously trying to invest in primary care? Okay, well, let's look at the policies. I think the tricky thing here is that you have a voluntary collaboration of payers and a federal government program. And so the question is, well, what is the lever of the state if you're making policy recommendations? We have a couple of draft policy statements here, but again, just like with the last set, you have free reign. You could add completely new policies, you could tweak these, make them stronger. But our initial set, committee statement of support for MPC work in aligning standards, quality metrics, practice supports, and payment models. A committee statement of support for MPC alignment with the Making Care Primary program. A third policy of encourage the legislature to identify opportunities to support and further multi-payer primary care alignment efforts. Any initial reaction to the statements?
Shane, this DC. I would definitely support the ideas behind all of these. Is there an actual statement that we still need to create, or is this what would be conveyed to our stakeholders?
Well, you can absolutely refine these. My candid opinion is that these don't have a lot of teeth in them, and so I think the question, or a good question for you all, is what could be done that has more teeth, if anything. One, just to try and connect the dots between the last conversation and this, one recommendation might be that to the extent that there is additional investments in primary care that's invested through this framework, or some portion of it's invested through this framework, and that might not be popular. This is just an example, but part of the reason you might want to do that is because it's not just about how you're influencing the payer behavior, and obviously they've got the skin in the game at this point and they're doing the hard work, but it's also about getting practices engaged in what is hopefully a better way of paying for healthcare that allows for sustainability, and again, just getting off that hamster wheel of fee for service. So I think you could be creative and push the bar more here if you want, but I think this is what we identified as like potentially a bare minimum thing you could do that's aligned with what the previous policy statements were. Jonathan?
Hi, thanks so much. I'm a total nerd and love the primary care alternative payment models and getting into the weeds of them. And so I've had the opportunity to look at some of the weeds that are available in the Making Care primary model. And it's a pretty complex model. Some of it is the same as CPC Plus, primary care first, but certain things are unique to Making Care primary that I think are worth stating and thinking about it as a group if we support or not. I'm specifically coming out and saying I am supporting these things, but figured it's worth calling out. So there are 3 tracks to the model: track 1, track 2, track 3. Track 1 is predominantly fee for service, and you could be up in track 1 for, I believe, 2 years. And then you gradually progress to track 2 and track 3, where you get more capitated models. What's unique about track 1 that is not in track 2 and track 3 is that there's upfront investments from Medicare that go directly, large lump sum payments tied to nothing, that go directly to primary care practices for the purposes of investment in building capacity. So one thing that we can conceivably support is not just Medicare upfront investments for track 1, but multi-payer upfront investments for track 1, so that there are multiple payers making an upfront investment in primary care practices throughout the state. That could be something that we could specifically support about alignment in the Making Care primary model. Another thing that's unique to the Making Care primary model is that in the past, population-based payments have been largely due to clinical complexity, which are based off of strictly HCC scores. What's new about this model is that they're integrating social and clinical complexity based off of measures that capture social complexity of a population. And so the intent there is to acknowledge the hard work that practices do, taking care of populations that have high degrees of housing instability, or high degrees of transportation challenges, or high degrees of other social instability. And so we can also conceivably support other payers making population-based payments that take into account the social complexity of primary care practices, in addition to the clinical complexity of primary care practices.
There are, thanks for talking about some of those characteristics. I think as part of bringing some information back, we can do, I think it was already noted earlier on this call, there's going to be multiple provider education opportunities, both directly through CMMI, but also as part of Washington's outreach efforts on supporting primary care through the multi-payer collaborative. But we can bring back some more summary level information for this group, or certainly make sure that there's more granular data available. There are links in this document, but I think we can help maybe call out some of the elements of the model that might be really conducive to recommendations on primary care investment as it ties back to that last point. I think it's also really important to note with MCP that that's really only going to apply to a limited set of providers in Washington, because you're talking about a specific set of the population, so Medicare, and not all providers are going to be eligible for the program, because if you're participating in certain other payment models with Medicare, you wouldn't be eligible for this one. And Judy, can you remind me, is it 350 practices or so they've estimated that would be eligible in Washington?
Yeah, 300, 350, something like that.
Yeah. So I think that's why that's at least in part why we were very conscientious about trying to paint the picture about, well, what is Washington doing? What is MCP doing? I know it's at a super high level. But then really highlighting that the alignment across the model is across the two different models is where the magic is going to happen, to the extent that there is magic to happen. So I think that's a great tee up. There's a lot of work here that's going to really piggyback on this general concept of investing in primary care, and it's an explicit charge. It's not just like, how do you get to the 12%, but what are the right ways to pay for primary care? So we'll bring back more information on that. We'll be careful about trying to highlight what some of the policy options are in this area. And then we'll continue to explore some of the other policy areas. I would recommend checking a look at the deck in between meetings, this deck, to see what was listed for some of the other policies if you hadn't, and start to think about them. Because as you can see, there's a lot of devil in the details, so we do really need to peel these onions and get to the core here of what we're going to recommend. So with that, I think I'm going to kick it back to Judy to wrap us up, because we're right about time.
Excellent. Yes, this is a great discussion, and thank you all for participating. And this first one took a long time, but I think that's to be expected. And I think we're on a really good track to sort of get through these. So at our next meeting, we're going to continue our discussion of policy proposals, and the recording and summary of this meeting will be posted shortly on the website. Our next committee meeting is August 31st at 2 p.m. and I look forward to seeing you all there. So thanks so much for your time and the excellent discussion. Take care.